Welcome to you all. Thank you for coming to the Woodrow Wilson International Center for Scholars. I'm Laura Listwood. I am the Secretary General of the Council of Women World Leaders, and I'd like to thank you all again for joining us today, which I think will be a very, very interesting and engaging panel. The Woodrow Wilson Center, for those of you who might not know, is the living memorial to the 28th President of the United States, an internationalist at heart, and therefore quite appropriate for this panel. The Wilson Center itself is nonpartisan, it's non-advocacy, and its purpose is to bring the world of ideas and practice together. Today's events actually culminate quite a bit of work from the Global Health Initiative here at the Woodrow Wilson Center. It's been a 2-year series on maternal health, and we, the Council of Women World Leaders, is quite pleased to be able to co-sponsor this event along with the generous funders, UNFPA, and the Maternal Health Task Force. Thank you, Tim, for that. The Council of Women World Leaders is the newest program of the Woodrow Wilson Center, although the council itself is 15 years old. It is made up of 46 women who currently or have held the position of president or prime minister of their country. In addition to which, the council also convenes women who hold the ministerial portfolio. And so our particular interest in this event is that we have on numerous occasions convened women ministers of health during the WHO annual meetings. So the council itself is quite dedicated to the whole issue of gender equality, to the issue of women's leadership, and certainly to this issue of maternal health. And we actually seek to empower and to raise the voice, the collective voice of women on important issues. As you've probably heard, if you've attended some of these dialogue series, greater political action in the United States and abroad is needed to move the maternal health agenda forward. GHIs, if you haven't picked it up already, please do. It's an excellent report. Delivering Solutions and Advancing Dialogue to Improve Maternal Health describes basically a holistic approach for addressing the health system challenges and social barriers that prevent women from accessing quality health care in developing countries. This forum is really one of the few forums dedicated to maternal health. The Woodrow Wilson Center's 2009 to 2011 Advancing Dialogue on Maternal Health series has brought together very senior level policymakers, academic researchers, members of the media, and NGO workers from the United States and abroad. This year in Kenya, you were working quite aggressively there, the Wilson Center and the African Population and Health Research Center convened 2 workshops on neglected maternal health issues with field workers and members of the Kenyan Parliament. To meet the challenges in maternal health, the series speakers recommended using existing low-cost solutions that build on our current knowledge base. And the interesting thing about all of this current knowledge base is, and I'm not one who normally is in the habit of quoting former Secretary of Defense Rumsfeld, but he had a phrase about the what's known, the knowns, and the known unknowns, and the unknown knowns, and the unknown unknowns. Well, there are very few unknown unknowns in this area. In fact, most everything is known, as it were. But the challenges are how to bring low-cost solutions, how to engage people, how to bring these kinds of programs to scale in countries, how to remove some of the barriers to these kinds of solutions. And the barriers, as we all know, can be economic, they can be political, they can be cultural, they can be social, they can be religious, all of these various barriers. The World Economic Forum's Gender Gap Report, which looks at the gaps between men and women resources on education, on health, on economics, and on political participation, actually show overall that gaps are closing between girls and boys' education and men and women's and girls and boys' health, access to health. But there have been some nagging, malingering gaps that haven't been closing in terms of health and education for girls and women. And precisely these sort of malingering, tougher to reach closing of gaps is exactly what this forum is about today. So let me congratulate the Wilson Center's GHI for the report, for looking forward to sharing we ourselves are looking forward to sharing this. We will be sending this out to all women ministers of health and to a number of male ministers we know who are actively involved in this. Now I'd like to turn the floor over to Kaylin Ostrowski, who is the Program Associate for the Global Health Initiative. It will say more about the Maternal Health Dialogue Series, introduce today's speakers, and chair the afternoon session. Again, thank you all for coming, for being interested in this, and I assure you you're going to have a very lively discussion. Kaylin?
Thank you, Laura. Good afternoon. Thank you for coming to today's report launch and event entitled Delivering Solutions, Advancing Dialogue to Improve Maternal Health. This is a very exciting day for us as we celebrate 2 years of maternal health dialogue sessions with our partners, the Maternal Health Task Force, UNFPA, USAID's Bureau for Global Health, and the African Population and Health Research Center located in Kenya. As Lisa just mentioned, the Woodrow Wilson Center is a nonpartisan, non-advocacy institution, and our unique agenda of bridging the world of ideas with the world of policy and practice has well poised us to host a dialogue series on maternal health issues that are oftentimes neglected and sometimes controversial. Since kicking off the series in 2009, we have convened 28 dialogue sessions with over 100 panelists, some of who I see in the audience today, and over 1,000 participants from all over the world. Program managers, researchers, donors, practitioners, midwives, religious leaders, and policymakers alike have joined the Wilson Center to address major challenges in the field, but also real opportunities and solutions for moving the maternal health agenda forward. As Lisa just mentioned, this past year we had the good fortune of partnering with the African Population and Health Research Center in Kenya to co-host 2 dialogue sessions in the field. Traveling to Nairobi, the series created a platform for field workers to share experiences and strategize real steps that were shared with all of us here in Washington during a live video conference. Through this unique partnership, U.S. and Kenyan-based program managers, donors, and policymakers, including several members of Kenyan's parliament, exchanged in direct and often very frank discussion about maternal health issues, advocacy areas, and concrete ways to scale up interventions. Throughout the series, both here in Washington and in Kenya, we always heard the same good news. We know how to save the lives of pregnant women and girls. As you will read in the report and witness in today's discussion, there were many lessons and evidence-based recommendations presented during the 2-year series. Thanks to our supporters, we were able to capture these strategies and synthesize the recommendations into a formal report so that we might be able to use this tool to share ideas with all of you today, but also disseminate the lessons learned to maternal health agents, donors, and policymakers here in Washington, the U.S., and abroad. Now, before I turn the floor over to the panelists, just a few housekeeping things. We are webcasting this event live, so what that means for you here in the audience is that when it comes time for Q&A, please wait for a colleague of mine to bring you a mic and present your name and affiliation prior to your question. All of the presentations and the report is online, so for those of you watching, you can follow along. And the webcast will eventually be turned into an archive video for all of you to follow later on in the future. As you enter the room today, you all received a copy of the report, but also the bios of our distinguished panelists. So I will not go over each person's background in great detail. However, I would like to briefly welcome and introduce all of our speakers, starting with Margaret Green, who co-authored today's report. Meg is, as many of you probably already know, has worked in the field for nearly 20 years on social and cultural determinants of health, reproductive health, development policy, and gender. She currently directs GreenWorks, which is a consulting group working to promote social change for health and development. Following Meg, we'll have Chacha Mwita, who is currently the head of policy engagement and communication at the African Population and Health Research Center and our go-to guy during the dialogue series in Kenya. Following Chacha, we will have Luc Desbernay, who is the Senior Maternal Health Advisor at the Technical Division for UNFPA. His main task there is to technically support the efforts conducted by all country offices in the field of maternal and newborn health. Last but not least, we have Tim Thomas, who is currently the Senior Advisor and Interim Director of the Maternal Health Task Force, which was originally born at Engender Health and is now housed at the Harvard School of Public Health. And you can read more about all of these panelists in your packets. So now I think I'll turn it over to you, Meg.
Good afternoon. It's really my great honor to be here and to have the opportunity to talk to you about the work of so many people over this 2-year period. First, I wanted to mention in particular the very, very productive partnership between the organizations listed here, the Woodrow Wilson Center with support and input from the Maternal Health Task Force, UNFPA, USAID's Bureau for Global Health, and the African Population and Health Research Center. And this diverse partnership was able to generate, to attract and generate many different events, perspectives, and what has come out of this collaboration, I think, is just enormously rich and has been enormously challenging to make into a concise publication, which I honestly initially would have expected to look more like a dictionary, but I'm glad it was tamed into the booklet that you have. So Kaylin Ostrowski and I, whose names are on the report, are just two people, but to capture the sort of process that led to the development of this report, you'd have to be able to hear the enormous chorus behind us with so many varied voices chiming together. So all of these events, hundreds of experts, and really thousands of participants, many appearing in person and many weighing in online through the webcast events. So from all of these separate events and recommendations emerged diverse yet highly compatible recommendations. And the basic message of the report, as has already been mentioned, is that we know what we need to do. We need to enumerate those things that we know already very carefully. Many of them are low cost. We just need to generate the political will to carry through on these things. So in our effort to organize and to simplify the many, many recommendations that emerged from these events, we divided them into 3 basic categories. First, a cluster that deal with social, economic, and cultural factors and gender inequalities, factors related to health systems, and then research and data demands that can also contribute to improvements in maternal health. So I'm just going to present some of the highlights in each of these areas and encourage you to look at the publication for more nuance and detail. So first, a couple of slides on the social, economic, and cultural factors and gender inequity. So how do social and economic factors limit access to the services that exist? What are the factors in people's households that prevent them from accessing services? There are many, and there are a number of specific things that need to be done. But first, the case needs to be made at the policy level that investing in women's health is not only good for women, but it's good for their families and nations, and particularly given the enormous costs that arise from poor health, the poor health of mothers, and the sort of ripples that run through their families and communities. A strong recommendation emerged on the need to invest in young women, a multi-sectoral kind of investment that focuses on their schooling, employment opportunities, and sexual and reproductive health. Another key recommendation was to improve nutrition for mothers and babies. And here, even though I'm using the term mothers and babies, one of the important pieces of this recommendation was the need to focus on women as individuals and to start with the nutritional investment way earlier to address household restrictive food practices, nutritional supplementation, treatment for worms, all of the kinds of things that cumulatively make women less prepared and less healthy when they face pregnancy and labor and delivery. And as part of this need to improve nutrition, there's a very important policy component as well, which is to engage ministries of agriculture and food programs to enter in dialogue with ministries of health and to have policy discussions on the contributions that nutrition can make to improving maternal health and alternative strategies for micronutrient delivery. A second set of these more social factors includes the need to incorporate a thorough understanding of local culture and social norms, and I think also not only an understanding and appreciation for those norms, but an eye to looking to the norms that may be harmful and that it might be possible to change in order to improve maternal health. Working with religious groups and faith-based organizations is also very important, and here one of the particular recommendations that stood out was the need to coordinate efforts. There's very often faith-based organizations in particular, but many times civil society organizations, more broadly speaking, are not well coordinated, and their efforts are not well coordinated, and to think more holistically about all of the activities that are going on in a particular setting for maternal health. And then finally, the great need to work with men in particular, not only to inform them of the danger signs and pregnancy complications, to increase the likelihood that future births might take place in healthcare facilities, to raise their awareness of the benefits of family planning, to address concerns about family planning, and to work on norm change that contributes to greater solidarity with women and greater support for women when they need care and attention. The second set of factors is health sector related and involve, I think, a number of factors that you would anticipate that have to do with the systems themselves, the existence of facilities and enough of them that provide emergency obstetric care, whether or not women are using those facilities, and the quality of that emergency obstetric care. Improving financing and accountability in health systems was also highlighted as a very important way of strengthening health systems. And in particular, I wanted to highlight 2 points: the decentralization of budget and financing processes to increase community participation and accountability, and also the need to expand community health insurance to increase, to address the issue of the costs to families of accessing healthcare services, including transportation. And that's, in general, with transportation, the cost issue is a very important dimension to address. And then finally, extending responsibility for maternal health to a broader set of workers, shifting tasks outward, yet recognizing that there are some tasks that must be performed, some roles that must be performed by the highest skilled workers. For this effort, it's really necessary to get the buy-in of not only the law and legislation, supportive legislation for this, but also endorsement from medical associations and medical professionals, because they have much at stake in the concentration of authority and responsibility in healthcare. Scaling up the training and availability of midwives, which is critical to improving maternal health globally. Another set of recommendations had to do with finding new applications for existing technologies, strengthening and coordinating existing e-health systems that are already in place, and really thinking carefully about equity and access to cell phones in particular when evaluating the impact or success of mobile health interventions. Another set of recommendations concerned the distribution of essential maternal health commodities, and in particular 4, oxytocin, misoprostol, magnesium sulfate, and manual vacuum aspirators that address the 3 leading causes of maternal mortality. So very specific and very concrete. And then the need to integrate HIV/AIDS and maternal health services. And here we have the UN WHO Prevention of Mother-to-Child Transmission model framework to guide that effort. In this integration also calls for donors to address the unmet need for contraception and family planning as a key contribution toward both maternal health and the prevention of HIV/AIDS. And a final point here is the need to address HIV-positive young people. Because of general ambivalence about the sexuality of young people, this is a group that is very neglected in health programs, and they can't be. They really need to be. They need to be addressed. The third area, the third cluster of factors that we in which people made recommendations concerned research and the need for additional data. So first, as I mentioned, thinking not only how mobile phones might strengthen and enhance health systems, but also to really understand the access issues. To think in very precise terms about the integration of maternal health more fully into the healthcare system, and to build the capacity of civil society and faith-based organizations whose ability to document and assess the work that they're doing for maternal health is quite limited, and yet they may be able to make important contributions, and so expanding that ability to describe and assess what it is that they are doing for maternal health. There was a sense from a couple of the panels that benchmarks and indicators are often too focused on contact with skilled birth attendants, and that there's a need to expand our assessment of our measures of the quality of the care and the context in which in the context of labor and delivery and where it takes place and so on. And that additional expanded set of indicators should also include information about referral networks and transportation. Another issue that arose and was discussed in very interesting ways in the meetings in Kenya was the need to address maternal health services in urban slums. When we think about transport difficulties, we often think about rural areas and women being carried across rivers and so on. But in urban areas, because many neighborhoods are dangerous, it's difficult for women to access services. In addition, in urban areas, services are often very expensive. And so both addressing those transport needs and thinking about establishing a system of vouchers that makes it possible for low-income women to access the superior services that exist in urban areas are both important recommendations. There was a good deal of discussion about the need to address maternal morbidities more broadly, just the prevalence of them, the effects that they have on women's lives and how they play out in the family. And the recommendation emerging in this area was that safe motherhood programs need to expand their focus to address these life-changing conditions, which include anemia, fistula, infertility, uterine prolapse, and maternal depression. And so just a little bit more precision on that point, because the emphasis on maternal morbidity was very strong in the recommendations, that we really need to understand the impact of when women are not well, what is the impact on their families and communities? How does this play out? And we need to have indicators such as near miss morbidity, rates of cesarean section, contraceptive prevalence. These are all closely associated with maternal mortality outcomes, and we need to be systematically collecting data on them, as well as the proportion of births that are attended by skilled birth attendants. I wanted to say a special word about the events with policymakers in Kenya to promote greater dialogue in the field. The 2011 dialogue series partnered with the African Population and Health Research Center to co-host a two-part dialogue series with local, national, and regional decision makers on effective policies and their implementation and how they were playing out. And what was fantastic about these in-country events was that it brought together field workers and policymakers, and they were very well attended by a whole range of people engaged in the health system in one way or another, and they were extremely successful engagements with policymakers. And I wanted to mention just a few there were many recommendations that emerged, excellent Kenya-specific recommendations, but that have that can easily be adapted and are applicable to other settings as well. And the ones I wanted to mention that are policy-related are, again, making the case between maternal death and economic loss at the policy level, making the case for investing in maternal health, and establishing a dialogue. I mentioned this in the context of nutrition, establishing a dialogue between ministries such as agriculture, finance, and health to talk more about coming together to make a difference to maternal health. The challenge of devolving human resources to rural areas and the need to recruit rural health workers from the areas in which they live, so that the ongoing problem of training and then losing workers to urban areas is diminished. Addressing the urban transport challenge, which I mentioned, so there's both rural and urban transport challenges, and they're quite different in nature. Conduct advocacy for finance, and here there was reference to the Abuja commitment on establishing investment levels in health and the need to conduct specific advocacy in that area. And then the need to extend sexual and reproductive health education as a major step toward prevention. So many positive and specific recommendations emerged, as you can see from looking at the publication. I did want to highlight these three big challenges. I'm sure there are others, but these are three that really stood out in looking over the recommendations overall. First, that in a handful of countries, more than half of all maternal deaths worldwide are occurring. And these are settings where it's very difficult to work effectively, where health systems are very weak, and so on. So that just makes it difficult when thinking about reducing maternal mortality at the global level to do so. Then I think in discussions about health systems, there are so many ambitions for health systems and the connections that people would like to make between different areas of health, and there's so many hopes for what the health system can accomplish, and some of the efforts to integrate specific health issues and community-led reforms can be real challenges for weak health systems. And finally, the issue of cesarean section, that how important it is to follow the WHO guidelines for cesarean section, recognizing when rates are too low and too high as issues and challenges, and the need to use these guidelines as a way of addressing the costs of cesarean section. So, as the dozens of experts who participated in the Advancing Policy Dialogue to Improve Maternal Health series made it clear, there are many, many different specific factors, most of which we know how to address. In the area of economic, social, and cultural factors and gender inequities, I mentioned women's access to education, employment opportunities, better nutrition across the life cycle can make a huge contribution to maternal health outcomes. And in addition, women's families and communities can find ways of being more supportive. Programs can help them anticipate what women might need during labor and delivery. And there's a very strong evidence base that exists to make the case at the policy level of how important it is to invest in maternal health. With regard to health system strengthening, again, there are many opportunities to prioritize and address women's health, opportunities that will improve health systems overall and not just for pregnant women and mothers. Opportunities to strengthen transport and referral systems, finance reform, workforce reconfiguration and training, and greater accountability through the devolution of decision-making and responsibility to the more local level. And of course, all of this is reinforced by improved monitoring and evaluation and more relevant research in many of the areas that I mentioned. So we have to continue to make the case to policymakers that sexual and reproductive health and services are fundamental to the well-being of young people. That maternal health is a key area of investment for the future of their countries. And as I think we all know, we know what we need to do, and it's our job to make the case more strongly so that these issues will be taken up and invested in. Thank you.
Thank you, Meg. That was an excellent presentation and overview of synthesizing all of the lessons and recommendations learned over the last 2 years. As Meg mentioned, it was a chorus behind the report, and I encourage all of you to check out in further detail those recommendations listed there. I also wanted to point out that the report has drawn upon past events, which are all listed online, including many of the event summaries, and you can watch those past events through the archive format. So check that out as well. We'll now hear from Chacha Mwita, who was our key contact and liaison for the African Population and Health Research Center in Kenya. Chacha?
Thank you very much. Good afternoon. Good evening. In Africa, we believe in saying hi before we start anything. So good evening. Thank you very much. Now, it's a privilege for me to be here, and especially given that this is one of the last activities related to this 3-year project. And I was sent by my organization to come here and present our gratitude for being made part of this. We are a research institution based in Nairobi. We do research capacity strengthening. That basically means training the next generation of African researchers in health and population issues. And we also do policy engagement and communication, which is why I'm here. I would like to start with a small warning that I'm not a health expert. I am not a demographer. I am a communicator. My health colleagues were supposed to be here, but there are various other things happening, and Catherine, she has been here before, wasn't able to come. So I hope I'll do justice. I have been asked to highlight how the North-South partnership with the Woodrow Wilson Center improved maternal health dialogue in Kenya. And I would like to deviate a bit so that we can have a real conversation. After all, the very specifics and nitty-gritties of the project have been very well elaborated by my colleague to the left, Meg Green. So I would like to tell you a story which will illustrate the extent to which this collaboration has been useful. It's a story that is very close to my heart. It's a story about my sister, Robbie. Now, Robbie was hardly 15 when she became pregnant, and she was she had finished her grade 8, what you would call grade 8 here in the United States, from the village. And I had given her a promise that if she passes well, she would come to Nairobi, which is a better place to live in, and pursue the rest of her studies from. So she passed well, and she came to Nairobi. But by the time she came to Nairobi, she was already expectant, and nobody knew. So one day in the middle of the night, we start hearing sobs from her room. And by we, I mean myself and my wife. So we go and check it out, and she says she wants to go to hospital. So I put her in a car, it's in the middle of the night, and drive her to hospital. Unfortunately, because of the area I live in, I landed in one of the most expensive hospitals in Nairobi. Remember, I was unaware, and neither was my wife, that she was expectant. She has a big body, she wears baggy clothes, and we thought it was some minor stomach pain or whatever. Then we get to hospital, and I am summoned inside the doctor's office, and I'm asked, who are you? I say, I am Chacha. And who is she to you? I say, she's my sister. The doctor asks, so you live with her? Yes. Do you have a wife and children, or is it just you and her? I'm like, I have a wife and children. Basically, he wanted, because she was a minor, he wanted to be sure that I am not responsible, because he's supposed to record, to inform the police that there is a guy here who has brought a minor to hospital to deliver. Anyway, to cut a long story short, he tells me that your sister is expectant and she has reached term. What she's going through are labor pains. Now, all of you can imagine my shock. Those are labor pains, and we have to admit her. Then, we start the process of admitting her, but the hospital, remember, is one of the most expensive in Nairobi. They ask for some $2,000 in cash, there and then, as deposit for admission. And I say, I don't have that money, because she's not covered, medical insurance. So I decide to get her out of that hospital and take her to another. So I asked the doctor one question: can he get to the next hospital? And the doctor says yes, she can get there. So in my hurry, I had left the ATM, I had left all these other things that are required to make life easier. So I called a friend of mine, and he brought me some little money. I got into the car again in the middle of the night and drove to a cheaper hospital in a much poorer neighborhood. And that is where Robbie delivered. Of course, after she delivered, I took her back home to her dad, who is my dad, because I thought this was now their responsibility, and it was too much, it was too big for me. Now, that story, and you can be sure I've cut it down a lot, captures a lot of the issues that Meg mentioned, and a lot of the issues that came out in the Nairobi dialogue sessions. And there are so many, but I would like to focus on only 4 of them in order to illustrate the importance of these sessions and how they affect people, including people like me. I'm sure Kalin Ostrowski wouldn't have guessed that I had a personal reason to attend those maternal health dialogue sessions in Nairobi from beginning to end. Now, first of all, please note that I am slightly better off than many people in Nairobi, and that is how I could afford to drive across the city from a rich neighborhood to a relatively poor neighborhood in order to be able to afford the services for my sister's delivery. In Nairobi especially, the slum areas do not have health facilities, that is to begin with. And number 2, they do not have roads on which you can drive to take a sick patient to hospital. And despite the fact that a lot of times we talk about traditional birth attendants, there aren't many traditional birth attendants in Nairobi slums. So the question of infrastructure came up a lot in those two sessions, and Meg has mentioned that. And the only reason that my sister survived was because I was able to get her in a car and drive. Even after one hospital became impossible, I still had the opportunity to move to the next hospital. Something that not many people in Nairobi, leave alone in rural Kenya, in Nairobi city, can do. And that is something to take note of. Secondly, the question of male involvement came in. Meg has already mentioned it. As you can see from my story, there are 3 males involved. Myself, of course, my dad, and the young man who was responsible for this. And so long as maternal health education mainly focuses on women, which has been the thrust in the past, in especially Africa, in Kenya, and in Nairobi specifically, then the maternal health challenges are unlikely to be solved pretty soon. Men must involve. I wish I somehow could tell a girl who was pregnant. I mean, even my wife is a woman. She couldn't tell, because there is a certain stigma attached to young girls becoming pregnant out of wedlock, and my sister did her best to hide the fact that she was expecting. And nobody knew up to the very end. But there are women now subsequently in the village when my sister went back who are saying it's not possible that people couldn't have told that this girl was expecting, because there are other things that they look for and that they spot, where they can tell a pregnant girl from 100 meters away, and we were unable to tell this. And as for the young man who was involved, of course, I think some basic education, which is the third point, wholesome education, would be useful. And this also came up in during these dialogue sessions, that we need to educate our young people. She mentioned it, especially adolescents and young people, especially girls. We need to educate them, and wholesomely, and this education has to include, responsible sexual behavior. It has to include contraception. It has to include its availability and access to it, and so on and so forth. And again, this is an issue that came up again and again during the Nairobi dialogue sessions. To what extent are contraceptives, for example, available and affordable? But that alone is not a solution. To what extent should young people, have information and knowledge on their sexual and reproductive health services and rights? I think if this education was there in a comprehensive fashion, I wouldn't have had to sit inside a doctor's clinic at night trying to prove my innocence. Number 4, I think, again, Meg mentioned it, and there are many other things. I will want to end these key issues there. It is the need to expand the field of players in maternal health, in the maternal health field. It's not just health professionals who have a role to play. In my story, for example, we have the Ministry of Roads. They do have a role to play. The Ministry of Education, they do have a role to play. To what extent do curriculums in our countries address questions to do with pregnancy and pregnancy outcomes? And to what extent should those curriculums address an issue like that? Other key issues, of course, are in this report that you have received today, and I would join Meg in asking you to read it. Now, my presentation would be incomplete if I do not give you a flavor of what happened after these dialogue sessions were held, and especially in the area of policy. Now, a number of policymakers in Kenya, we call them MPs, the highest level, parliamentary policy-making level, attended these dialogue sessions. And I would like to say that in Africa and in Kenya particularly, it's not very easy to get policymakers to attend any meeting at all. They are busy doing many important things, and quite a few unimportant ones. But nonetheless, it's not easy to get them to attend anything. But we managed to get them, and a very important constituency of them, to attend both maternal health dialogue series in Nairobi. And all of them pledged to do one or two things about what they had learned from the sessions. Honorable Lina Kilimo Chebi, she was quoted here, is one of those who attended, and she said at the sessions that she had built maternal shelters. These are places in between home and hospital where mothers can go before their delivery date and wait for the hour that the labor pains will begin, and then they can be rushed to hospital. And these shelters usually also do have midwives, so if it's an emergency, they can also deliver there, so long as they do not need those more complex operations. They can also deliver there. Now, Lina Kilimo Chebi has pledged, and I believe she's a very tough lady, to increase the number of shelters in her own constituency and in her area, which means other constituencies around hers, which are represented by men, and without saying that men are worse strategists in maternal health area, but they need a bit of help from the likes of Chebi, and she has made that undertaking. Honorable Kiplagat sits on the Budget Committee of Parliament, and he has pledged to work tirelessly in order to ensure that there are more resources allocated to maternal health. There is an MP who did not attend our dialogue sessions, but I have had the opportunity to meet him and talk to him following this maternal health dialogue series. In fact, one of the things he did was to blame me for not inviting him to them, but the point is he didn't seem like an immediate kind of target for the sessions. However, Engineer Rege has pledged, he's very into IT, has pledged to institute mechanisms within his own constituency, especially with respect to prenatal care, to use ITs in order to improve maternal health outcomes. Specifically, what he has in mind is the concept, the notion of e-medicine, where he can have a doctor in Nairobi but link using technology to his rural constituency, have a day once a month where mothers who are expecting can go and have direct consultations with this doctor from remote areas. And I think he means it, because he has done something else along the lines of using IT in order to deliver services to his people. And of course, Honorable Ekweturo has pledged that in Kenya we have 2 ministries of health, and in his opinion, this is basically a duplication of efforts and a waste of resources. So he has pledged to, lobby his fellow MPs so that Kenya does have one ministry, one dedicated ministry of health, and use the resources that are duplicated in the other ministry to strengthen the units within the Ministry of Health, including the Division of Reproductive Health, which is a key division within the Ministry of Health. However, that notwithstanding, Kenya now has a new constitution and the number of ministries are limited, and the reason we have 2 is that ministries had to be created to accommodate a few more people as ministers and permanent secretaries and the bureaucracy and so on and so forth. But now we do have a new constitution which actually limits the number of ministries, and it is highly unlikely that going forward after next year we'll have 2 ministries of health, and a few other things that are happening. Now, in conclusion, what is APHRC doing about APHRC is the African Population and Health Research Center, where I come from, about these issues. Where do we move to next? Now, as I said earlier, APHRC does three things. We do research, and this addresses the question that Meg mentioned of research and data gathering to inform policy. APHRC does research capacity strengthening, offering opportunities to the next generation of African researchers in health and population, and APHRC does policy engagement and communication. We have been going through a process of having creating our strategic plan for next year going forward. And I'm happy to report here that we have decided to maintain, we have several research areas and research themes, and we have decided to maintain two of them as separate. And one of them is the health research theme, and the other one is the population dynamics and reproductive health research theme. The reason for doing that is actually to give greater room and greater opportunity under the population dynamics and reproductive health research theme for greater research in that particular area to address issues in that area, of course, including the very important issue of maternal health. In research capacity strengthening, we are undergoing, we have a discussion that is ongoing within the institution on whether or not to bring a reproductive health research expert whose role would be to focus on mentoring, not just, our own researchers, but any other person who can have the proximity to arrive, at APHRC or in touch with this research expert to mentor them in the area of reproductive health research. In the area of policy engagement and communication, which is where I come from, we are doing a variety of things, but I would like to mention two that are directly related to this issue. The first one is we want, under our next strategic plan, to set up a resource center which would act as some sort of one-stop shop for information, especially to policymakers on various issues, including this very important issue. And number two, we are part of the the World Health Organization regional agenda on reproductive health. And one of the key things that is being considered as part of this is to make maternal mortality a notifiable event. By that I mean, if a mother dies or a woman dies trying to give birth or due to pregnancy-related complications, local government officers must be informed. And one of the best examples that is given, of course, is the example of Liberia, and we want in Kenya, through this World Health Organization agenda, we want Kenya to be the same, is that the office of the president must be notified. And the reason for notifying, for making it notifiable, is because, number one, solutions will obviously be found. And number two, if people know that if a mother tries to give birth, or if a woman dies because of pregnancy-related complications, and the office of the president is informed, there is likely to be action to ensure that that does not happen. Now, although this addresses only maternal mortality and not probably other aspects, you realize that if it is well done, it will address those other aspects as well. And of course, finally, with respect to policy engagement and communication, we have expanded, thanks to this, our partnerships, of course, across continents, across seas, to include the Woodrow Wilson Center. Now, I would say that this particular project, which was a North-South collaboration, helped bring together a cross-section of people who have an interest in maternal health to discuss these issues and have various undertakings, some of which are at a very personal level. I made a decision which I can tell you later. And I'm sure our MPs made decisions which they are already carrying out. And it set the stage for future collaborations. And I think it's one of those classic examples of linking the world of ideas with the world of policy, which is what the Woodrow Wilson Center is here to do, and of course the African population through its policy engagement and communication unit. I would like to stop there and thank you very much for listening to me, and express the hope that we can meet some other time. Thank you.
Thank you very much, Chacha, for sharing your personal story. And you're right, I had no idea when we were in Kenya that there was a personal connection there. And thank you also for sharing the lessons learned that there were so many issues that we talked about in Kenya, and I think the 4 that you highlighted was a good overview of those 2 workshops. So now we will turn the floor over to Luc de Bernay.
Thank you, Kaline. Thank you very much, and thank you to all of you for being here. I think it's an important meeting for us, and my first words will be to thank the Woodrow Wilson Center, because this report, I think, it's impressive in the way it's addressing so many issues and reflecting on the work which has been done. And thank you also for writing this report in this way. I think this gives a lot of substance and summarize really, perhaps not all, but at least a great bulk of the key issues that we have to address if we want to be serious about maternal mortality reduction. So really a sincere thanks for your team, for the center, and also for the pleasure of the collaboration with the Maternal Health Task Force. I think we had an excellent discussion where we are talking about establishing this program. So my first point is to say that I think it's a good idea. We need to continue, and I have the support of my management, and I want to express the fact that, and I start with that we would like to really continue that. Why? Because the dialogue is one of the most important things that we have to do in maternal health. Maternal health is addressing a very complex system, and we know that. So there is no simple ways and simple solution. We insist to say we know what we want or what we need to do. We know what works, yes, because in many countries maternal mortality has been reduced, and even we don't talk too much about that in the rich countries. But saying that, in fact, when you go to the details, yes, we know about technical issues. We know that cesarean section is good for that. We know how to treat a PPH, etc. But if you go a little beyond that, immediately we have a lot of discussion and divergence and eventually opposition. And I have some excellent colleagues in this room, and they will not disagree with me to say that it's a long, long fight to try to harmonize and to convince, even within the maternal health community, what are the key strategies to ensure that we will make progress and we will accelerate the progress. So I think the dialogue is critical between all the actors which are more or less engaged and who have a part to play in the fight to reduce maternal mortality. And we know also that the most important, perhaps, is the political will. So the experience of Kenya, and I will come back to that, I think is absolutely amazing, and I think we need to think more about how we can stimulate this at country level, and then between the different countries, south-south and also north-south or south-north. So dialogue, we need to continue to work on this. Reason why immediately I wanted to say that we are happy with what we have done, what the Wilder Center has done with this report, and I think we need to continue and to really think about how we can maximize, how we can build on what has been done already. The year of 2010 and 11 are, I think, very important for maternal health. First of all, not only because we have never received so much support, we are a little anxious because we would like that this support continue to increase, which is not given, but this has given to many actors more capacity to move, and we see that finally, after 20 years of hesitation and discussion among the partners, we can report on progress. Totally inequitably, this progress is totally not equal. It's really concerning that we see that in many African countries, particularly, the progress is not very much. Even some countries have shown increasing maternal mortality for different reasons. So we are far from being happy, but there is some proof that we can move. And again, many examples when the political has been clear about the strategies to support the strengthening of the health system with clear decision made. This was absolutely critical. I would like to also report, and you know that finally the international community has been able to recognize that we have 3 pillars where we need to invest definitively to reduce maternal mortality. Family planning, we have not talked too much about that, and I think this is an issue we need to come back to. The issue of human resources, qualified professional human resources during pregnancy and particularly at childbirth, and the issue of managing complications, all the issue of emergency obstetric care, which is a big challenge to ensure that services will be available, accessible, and of quality all the week, day and night, in countries where it's difficult to circulate, where the roads are not good, where the personnel is very, very rare, etc., etc. So we know what to do, but we need also to improve our capacity to assist governments and assist communities to implement what is supposed to work. I was saying that the 2 last years have been important also for other reasons. This collaboration started before the UN Secretary General decided to launch this Every Woman and Every Child strategy worldwide. And I think this tool, this network, this capacity of ensuring a good quality of dialogue is a fantastic tool to support this initiative. So I would say that we are on the right move, and we are probably useful, and we need to increase this capacity. It's also important for us because we are making progress at the international community level to ensure that the UNs are working all together better for maternal health. Again, it's a complex issue. Each agency has a role to play, and for the moment, the agency were working in very different ways and not very well coordinating. We have created this H4+. This took 5-6 years to implement it. It is working now. It has been recognized by the UN Secretary General. We are trying to make progress at country level, particularly where the UN should support the government in the right way. So this is going. All the thematic which have been addressed during these 2 years are reflected more or less and inspiring also what we are doing. So participating in this dialogue is also extremely rich for us. And I would not go to all the issues, but you mentioned, for example, that 6 countries in the world are responsible for around 60% of the maternal death. And we have created 2 years ago now with the H4+, an initiative created, named High Burden Country Initiative, precisely to address the issue of human resources at community level in these 7 countries. So just to say that what we are talking about here is not just talking, but we are trying to address systematically what we are talking about. The Every Woman and Every Child initiative is also reinforcing its capacity of action through putting in place some specific commissions. And last example, we are fighting to ensure that in the essential commodities, MVA will be part of that. This is amazing, but we are talking about oxytocin or heterotonics, we are talking about magnesium sulfate. Yes, excellent. We are not talking about anesthesia drugs, which is absolutely critical to save lives. And we are not talking about MVA. And even we have been forced to push for contraceptives, but no contraceptives are there. So, you know, we know what to do, but it's permanent fight. The year is also important because 7 billion. And I think we talk about youth, adolescents. This is an enormous challenge that we have in front of us. And for the moment, we are really not serious about that. And we have to see how we can address that. Access to sexual reproductive health, yes, surely. How to do that? Creating services for youth, adolescents, we don't know. It's not perhaps the right way. How to make sure that adolescents and youth will receive the education that they need, the support that they need to address their own life in the way they want to address it, etc. It's an immense challenge. It's related to all the sectors of the society, of the economy, and obviously there is a link with sexual reproductive health and a link with maternal mortality. So we need to be part of this move, and is extremely important. When we had this idea of working with Kenya, in fact, not with Kenya, the idea was to work with, to try to not create a dialogue only in Washington, but to really address concretely what we were supposed to address during these discussions and presentations with a number of experts, as it has been said. And we look for different ways of doing that. And we are very, very happy to hear, particularly what you just said, because it was, I think, exactly what we wanted to have, that this dialogue in Washington could stimulate the dialogue between the different parts of interest parts in Kenya or in other countries. And now we have to think more about how we can, if we decide to continue to do this work. I think, first of all, we have a responsibility with Kenya. So we need to see how we will follow up. We have contributed to something. We cannot say, okay, we have done this one, now we go to another one. I think we need to continue to be in contact with you, be in dialogue with you, and to see how we can support, and perhaps how we can report also on what you mentioned, a lot of commitments made, and how this commitment will be made is important. So first, we need to continue to work with you. Second, we need to take this example and to see how we can go to other countries, English-speaking countries, at least, but it's already something extremely large. So we are very willing to discuss that with you as soon as possible, and in dialogue with you, so we can use this experience with others. Another thing important this year for us has been the launch of the State of the World Midwifery Report. You know, addressing a gray area when we don't know who is working where, doing what, in majority of countries, where the government are not equipped to know what happened really in the field. This has been an excellent and very interesting partnership also, because this idea came during the last Women Deliver conference in Washington, and immediately a number of key partners decided to go and to say, okay, we know that midwives are important. We have no data. We don't know where the countries are, so we need to move on that together. And in 8 months, a report showing the weakness of the data. But this is the pure reality on which we need to work now to improve the things. This report has been done, and I think we can say that it's a very important achievement. So I said I will not go through all the technical or less technical but very important issues that were addressed during these 2 years. But again, to repeat that this is very important for us and very inspiring. And we can, I'm sure, if I go through, reflect in all the issues, how we are trying to address that. For the future, I would like to say 2 or 3 things that perhaps could be interesting in the discussion so we can have an opinion on that, on what we should do. I said briefly we need to find ways to improve the dissemination of what we are doing and to make it available and to make it used by more people. I don't know how to do that, but I think we can do better. And second, I said already that the experience with Kenya has to be very well analyzed, and so we can see how we can expand during the coming years with other countries to stimulate this internal and inter-country dialogue. Now, issues perhaps which have been not enough addressed for us, I would try just to list some very briefly. Community mobilization. First of all, let me start with one thing, integration HIV and MNH. I think this is also a very good move, and this session has been very useful for us because we are strengthening the collaboration between the HIV programs and maternal health programs at all levels, including at international level, through partnerships. And we had recently in New York a very interesting meeting between HIV programs and maternal health program. And you would say, finally, because we are talking about that during the last 20 years. But for many reasons, no, it's totally possible to have a dialogue because the two programs have finally understood that they cannot move without being together if we want to make progress. So this is important. Quality of care has been said. We have a lot to do more about quality of care and to say about that. So I think it will be a very good topic. South-South and support to Southern institutions, inviting more Southern institutions to be with us and to work on this would be also probably an important point. How to increase national capacities for training and for managing and monitoring is especially important and difficult, and we think that it could be something that we should explore. You started by addressing the complexity through gender inequalities. I mentioned family planning. We have the youth and adolescent. I think in all this we have a lot more to say. And so we look forward to see how we can move on this. And community mobilization, also I was thinking about HIV because HIV can be a really inspiring move in this regard. Maternal health has not been successful enough to mobilize the woman to fight against maternal mortality. I would like to stop to say that it's also a very important year that we are going through in 2012. We are in Washington, and it's not by chance. We are in Washington because Washington is the capital city of an important state. And this state has a very important role to play, including in maternal health. It is playing a very important role. And I want to say that we have been extremely happy to see how the collaboration with the American institution in the field of sexual reproductive health have been improved during the last years. So we are very looking at the future and looking at this 2012 years because we hope that this collaboration can really improve and continue to improve. And I would close to saying that one of the best, and perhaps the best advocate that we have for sexual reproductive health is the Secretary of State of the US. So we are very pleased, again, to continue this collaboration. I think it has been extremely rich, extremely innovative, and rich for us, and I hope for the participants. So on these positive words, I will stop to talk. Thank you very much.
Thank you, Luc. Thank you for highlighting the important role of dialogue and the response to maternal mortality and for highlighting some emerging areas that still need to be addressed. We will move right along to Tim Thomas.
Hi. Thanks, Kaylin. And thanks to my previous speakers who are, I could not illuminate more on what they said. I just want to make a brief statement on behalf of the Maternal Health Task Force. We are very grateful to the Woodrow Wilson International Center for Scholars for hosting this dialogue series, to UNFPA for their collaboration, and to USAID for providing valuable technical assistance to setting the agenda for these dialogues. We at the Maternal Health Task Force are very proud of this series. We deem it one of the most successful projects we've been able to sponsor over our short 2.5, nearing on 3 years in our first phase. I would like to introduce a couple of my colleagues who are in the audience today who have been integral to making this dialogue series work and indeed in helping the task force achieve its goals. Dr. Anne Blank is the former director of the Maternal Health Task Force. She has now moved on to a small role at the Population Council. And behind Anne is Chris Lindahl, who is an important part of our knowledge management team. And I think if any of you have been following our blogs, our tweets, our website, you'll know Chris's name. Watching from afar is the rest of our team: Raji Mohanam, Emily Puckert, and Hannah Schreiner. I'm sending you a virtual shout-out to say thank you for all the work you've been doing on this series. Just quickly, the task force has had a unique mandate. We called it the 3 C's: convening, catalyzing, and communicating, more than 3 C's. We were founded on the premise that the maternal health field needed a hub, a safe space, a neutral space to debate difficult issues and where we could reach consensus in the field and exchange knowledge, new knowledge, old knowledge, that will inform continued ongoing dialogues like this one and identify innovative solutions to some age-old problems. Maternal health is, of course, as we all know, deeply entrenched in the human condition, and it is eradicable, and we are determined to see that through, if not in my generation, then certainly in the next. And I see the next generation well attending and well populated in this dialogue series, and that's very heartening. We were also mandated to engage allied fields. There's many, as we have heard from Meg and Luc and Chacha, there are many fields that contribute to our collective goal to eradicating preventable maternal mortality and morbidity: nutrition, transportation, HIV/AIDS, economic development, disaster relief, religion, so many more. Our hope has that we've been able to seed discussions about how these allied fields work together and work with the maternal health field that we hope those seeds will take root and flourish. Luc just mentioned family planning. It's been mentioned. It is oftentimes not mentioned enough. Some people call it an allied field to maternal health. I see it as the same field. I think it's a no-brainer. The fewer pregnancies a woman has, obviously, the less likely she will die or be disabled in pregnancy and childbirth. So we have been doing as much as we can over the past 2-3 years to integrate the Maternal Health Task Force with a lot of family planning efforts. And being at home at Engender Health in New York has allowed us to do that. We don't need to point to the positive, or we should point to the positives that we're seeing in maternal health. Obviously, the declines that both estimates came out with in 2010, but also a very encouraging increase in global attention to these issues. Women Deliver, in 2007, really issued the first global warning that MDG5 is the goal that's most off course, and people took heed and listen to that. As Luc just mentioned, the Secretary General's Every Woman, Every Child campaign that's also bolstered by $44 million in commitments, both in kind and cash, from a range of actors, from the corporate sector to national governments, donor agencies. People are rallying around the Secretary General on this call, and I hope it will be his legacy. The White Ribbon Alliance, as we all know, one of the greatest organizations who are galvanizing grassroots activism, creating demand for improved maternal health outcomes in country where the burdens are highest. And then a very encouraging new development from one of the largest corporate giants in the world, Merck. Merck has come out with a new campaign called Merck for Mothers. It's a huge corporate social responsibility initiative offering a significant boost in private sector funding to maternal health. So that is incredibly encouraging. With all this new attention to maternal health has also come a wealth of new knowledge. One of the jobs the Maternal Health Task Force has taken on is to manage that knowledge. There's this field called knowledge management, which when we started the task force, Ann and I scratched our heads and says, what is that? And we did a lot of work around trying to figure out what it is, and thankfully we brought on a great team who have been able to help us manage this vast increase in knowledge that's been generated or aggregated through the virtual world. Lots more needs to be done on that. We intend to continue working on managing maternal health knowledge and making it more accessible for people who need it, and making it more available to the people who make policies and around government policies and donor policies. So these dialogues have been an attempt to raise a discussion on emerging and neglected maternal health issues and to foster this dialogue that Luke talks about as being so vitally important to this field, and we agree. There's a plethora of passionate and dedicated experts in maternal health who often have very, very viable yet differing ideas, and we're trying to bring them together to talk about them. This report represents that. It's a broad, Meg, I think, and Kaylin have brought together this broad range of thinking in the maternal health field, much of which we know needs more consensus. We are happy to know that this dialogue series has been taking place alongside a lot of other exciting new developments in the global response to maternal health, most notably the World Bank's report on gender equity and development. Very encouraging the bank is looking into this, and it seems like they'll be going further. My colleague Ann Blank and her colleague John Roche, who wrote a very interesting paper on the patterns of the age patterns of maternal mortality, which shows some unexpected findings that may challenge some of the experts who are cited even in this report. So even as this report has gone to print, new knowledge has been generated, and the field keeps changing and evolving. We're also excited by a new working group at the Reproductive Health Supplies Coalition that's seeking ways to integrate the essential maternal health commodities that Luke was just mentioning into their programming. So we feel that a lot of the dialogues that we've been having on these emerging and neglected issues have been taking flight in parallel to what we've been doing, and that's exciting. Just one last personal note on this. I was not a maternal health expert when I came into this field. I knew it sort of generally, but I was a bit naive, I have to admit. And what I think one of the biggest takeaways I have from the first phase of the Maternal Health Task Force, and we're moving into our second phase, is the multi-sectoralism, is that a word, of maternal health. It's not only about health, we know this. It's derived, maternal mortality and morbidity are derived from a complex causal chain of gender inequity traditions that are deeply embedded in all facets of so many societies around this world. I don't think we can say it too much. Until women and girls have equal access to education, rights, economic opportunity, and quality health care, they will continue to die needlessly in pregnancy and childbirth. And it's our collective goal in this room and for everybody who's watching and all the stakeholders of the Maternal Health Task Force and UNFPA and APHRC and all the organizations that have been represented in this dialogue series to make a world where women do not need to die needlessly giving life. Thank you.
Thank you, Tim. We will now open it up for a discussion, as I'm sure many of you have questions for our distinguished panelists. Please wait for a mic to come to you, and remember to announce your name and affiliation. Who would like to go first?
May I? I'd like to call on Ann, if I may. Ann Blank is one of the world's leading researchers in maternal health and mortality and morbidity. She's the co-author of a very important report on morbidities. And I'd like to ask Ann if she would mind saying a few words about where she sees the research gaps that we still need to fill and how those gaps might get filled. And putting you on the spot, do you mind?
Gee, thanks, Tim. Hi. I'm going to answer a different question, slightly different question. Because I was sitting here as listening to Meg go over all of the recommendations from the different dialogues and the commentary on all of that, and I was thinking to myself, well, if we had to go back and do it again, come up with an agenda of dialogues, which ones do we wish we had done that we didn't do, or we didn't have time for? And I think there's at least one, there's probably two I can think of that I think would be good, and maybe we can do those. You can do those in the future. One is, I think, some specific attention to adolescence, and I think specifically around understanding what it is that adolescents need aside from sexual and reproductive health, education, and services that would improve, that could improve not only maternal health, but everything else that adolescents are doing. And I think that there's a lot of new work around that topic, which could be very interesting to bring together people who are working on, not just in the health sector, but as everyone here probably knows, in livelihoods and financial literacy and other issues. That's one. The second one that I think we might want to pay more attention to is the idea that everyone keeps saying we know what to do, we know something about how to do it. All we need is political will. Well, I would argue, and I think my favorite political scientist who is sitting right here would agree with me, that what we don't know how to do is get the political will. I think that we have been not so good at, because people keep saying all we need is political will, where my question is, how do you get political will? And I think there are other public health, areas of public health and other areas in general in sort of social development that have been better at generating political will than the maternal health field has. So I think it would be great to get together some grassroots activists, some political scientists, and some other people to talk about that. So those two things are on my wish list. I'll think of some more.
Thank you, Anne. We've got a question up here in the front, and then we'll take a couple at a time. So we'll do this one on the front and work our way back.
Good evening. My name is Josie Bass. I'm president of Alpha Consortium. We've been working in and out of Kenya for the past 10 years, and one of our focuses has been in addressing the political will, ensuring that women are adequately trained and given the skill sets to seek elected office in their respective nations. And we've had some success in Kenya. Out of our original classes came the Honorable Esther Kino, the Honorable Joyce Laboso, the Honorable Lina Kila Chebe. And so it's especially heartening to hear that process, those causal connections, that chain has moved as women seek and secure elected seats. They begin to change the policy that affects their lives and that drives the lives of the women of Kenya. And so we see Lena, who has learned some very hard lessons throughout her short political career, who has become even more courageous and proactive in her stances. Joyce Laboso, who didn't seek to run for elected office, but was appointed out of a tragedy, who is learning that process. On the Kenya Supreme Court, Njuke Ndungo, youngest member on the new Kenyan Supreme Court, and in her first years in Parliament sought to change the history of Kenya by introducing Sex Crimes Act, and scared the living bejesus out of everyone because she talked about chemical castration and therefore couldn't secure a vote from anybody else in Parliament. None of the men would vote for. So we had to go in and talk about new educational skills and national platforms and how you leverage your vote. And she came back at it again until in 2006, 2007, the Sex Crimes Act of Kenya were passed under Njoki. 26 new criminalization that will protect women and children, young girls. And so it's a process that begins, and this is the next connection of those dots. And I really hope that you, Mr. Chaka, I hope that you will go back and build on that with these women parliamentarians and help them to see this is the next step in helping the women to come from the villages again to the policy formation of Kenya. Thank you.
Thank you. We'll take one or two more questions back there.
Thank you. My name is Daniel Sanger. I'm from the State Department's Global Health Initiative. I will make the point of saying that I'm speaking informally and not on behalf of the State Department of the U.S. government. But I wanted to answer a point about raising political will, because it's something that I spend a lot of time thinking about. It's something that I teach about at university, and I think there are things to be done on that. In reading through the recommendations here, I thought they were extremely well done. But for anyone who's worked in this field, there was very little here that you looked at and went, "Oh my God, I never realized that was." I mean, these are things that we've been talking about in one venue or another for quite some time. But I would point out the very first recommendation says, make the case at the policy level that investing in women's health is a good economics. And I think that is one foundational element of raising political will. We've been working within the U.S. government on this issue. I can tell you, I pulled together all the work that's been done in peer-reviewed research that looks at the economic impact of it. It's fairly sparse by most standards, and I'm detailed to State Department from the National Institutes of Health, so I understand kind of what makes for a research case. This is a poorly made case at this point, and I think there's a great deal of work to be done to document and explain the economic argument. Because if you look historically, the health issues that become national priorities are things that affect either the national sovereignty and security of a country or their economic security. And that's maybe a sad statement on the way that governments make decisions, but it is very realistic. And I think that if we want to advance this issue, we need to provide more concrete elements to inform that argument that this is the right thing to do, not because it's altruistic, not because we're good people. All of those are true, but that's not what will drive people around the issue. I think it's ultimately the economic argument that has to support that. And there's a lot of places where that information may be sitting, but it hasn't been collected and analyzed in a meaningful way.
Great, thank you. Maybe now's a good time to ask the panel to respond. Luke, did you want to respond to, you had mentioned in your presentation the need to increase capacity to assist governments, and I think we've all been talking about the political will. Do you want to address some of those things?
No, I'm very happy to see that we agree that this is an area where we need to put more brain, and I think this in the future we can see the way of addressing that and trying to connect between them, different initiatives taken here and there to see how we can have lessons on that. And your point about the fact that it's very rarely studied and documented, it's pushing for more discussion on that. I think the role we can have is to highlight the point where more research, more work has to be done, and if we can serve that, it's perfect. Yeah.
Just a quick note, the World Bank's Gender Equity and Development Report does not do what you're looking for in terms of the specific data, but I am aware of exercises underway that will be, I believe, rolled out in Women Deliver 2013 that is going to provide us with more economic data, possibly not everything we're looking for, but the need has been acknowledged. And the economists, I think, I hear are working on it, and we should hear more in the next couple of years.
Chacha, do you want to add anything about the access to political makers? Witnessing it in Kenya, it was very obvious that there was a strong presence of members of parliament at the meetings, and you had mentioned that they continued to follow up on some of the action steps given. So I wonder if there's some examples you could share of how we might learn from that.
Yeah. Actually, the question of political will is a question that we have had to think about a lot at APHRC because this type of research we do has to be policy relevant. We don't just do any research. We do it for policy and practice. And if our research fails to inform policy and practice, then we should not exist. And one way that we ensure this happens is, of course, direct face-to-face meetings with these policymakers. The problem is, and which addresses the question, the problem is that usually we tend to engage them a little bit in the day. A research takes 3, 4, 5 years, and then once we have completed it, that is when we go to them with the findings and with suggestions and ideas on what could be done. Unfortunately, by that time, it's a little too late. Their policy priorities have changed. You know how the political terrain is usually, very turbulent. What was relevant 5 years ago when the research began might not be relevant 5 years later when the research is completed. However, what we are doing right now and what in the strategic plan that I spoke about is to engage policymakers in designing the research projects so that from the very beginning they know what we are doing, they know what we are up to, and most importantly, they get the opportunity to include where it permits their own questions that they would like that particular research project to answer for their own purposes. As you all know, politics is a little bit, it's a sensitive area. And a lot of times politicians ask tough questions, simple questions like, who is your donor? It's simple, but it's actually very tough in the sense that some politicians, like in America, there is the typical divide of, conservative and liberals and so on and so forth. Those are things that we have also to deal with in our own backyards. And so we think that engaging them at the very beginning is not only helpful in improving the research project, but it's also helpful in helping us anticipate some of the problems that we might face when it comes to engaging with them later on at the research stage. Thank you. I mean at the dissemination stage. Thanks.
Thank you.
Hi there, Amanda Classing from Human Rights Watch in the Women's Rights Division. First of all, thank you very much for the report and for this panel. I just have two very quick questions for the panel. One is, we heard a little bit about gender inequity and also about family planning, but I'm wondering if during any of the dialogues there was a discussion of sexual-based or gender-based violence and the impact that has on maternal health and reproductive health. And also on the question of accountability, I think there's some mention of the human rights-based approach to this issue, but I was wondering if during the dialogues, if there was anything more concrete about what accountability looks like or an accountability mechanism, how we can actually hold governments to account or hold individual actors to account when policies or protocols fail. Thank you.
Thank you. Do we want to take one or two more? Maybe Marge, start in the middle.
Well, I would like to echo congratulations to all the very energetic speakers that are up there on the dais. It was wonderful to hear you, and I really think that the dialogue does need to continue in a very big way. I wanted to address some of the economic issue, and I think one of the panels that you had, the one on maternal morbidity, began to explore how big the problem was or is. We still don't have a lot of data. We need a lot more. What we did find in the Bangladesh data was that essentially even though we could decrease maternal mortality, we couldn't decrease morbidity, and that continued to be very large. What we don't know is how much that costs. In other words, we don't know how many productivity days are lost because of that continued morbidity. And it's not just the morbidity around intrapartum. It's the morbidity that continues onward afterwards. And there are no weights, there's no discounting. We don't know that kind of information. So the ability to put together the economic package really continues to be a major piece on the agenda. And I do hope that you'll continue to look at that, promote that as an area of research.
Great, thank you. Take one more right here.
Hi, my name is Juan Carlos Mendez. I'm a private consultant, but also a research associate at Grupo Faro, which is an Ecuadorian think tank in South America. I just wanted to keep on going with the economics part of it because we at the moment, and I'm going to speak particularly with the Ecuadorian case, so that may be a bit biased, but we're having a bit of problem in trying to convince decision makers that it's an economically good decision to invest more in these topics. And it has to be said that the investment in developing countries as a percentage of GDP is still very, very low, and it's one of the problems of sustainability in these aspects. But also to echo what was just said, we found that that's the only thing that has to be done. So the research, although the economics part of investing in health towards economic growth, because I think in the end what decision makers are very concerned with in developing countries is growth. And the economic aspects of investing more in health towards economic growth, it's very hard. And there is a very, very good part of that in that with maternal health it's easier, because the causality and economic models of investing in health towards economic growth has had a few problems in the past, but experiments that have to do with maternal health and also with nutrition towards getting more productive, a more productive labor force, and in the end also expanding the production frontier, which leads towards an economic growth, is what decision makers at the moment are very interested in. And also that's the experience in Ecuador. I think we're winning the battle towards trying to convince them that it is a good investment and that it has nutrition and maternal health issues have and a long-term effect on economic growth.
Great, thank you. Well, I think I can go ahead and answer the question about the gender-based violence. Over the course of the last 2 years, none of the events specifically had that as a topic that we specifically addressed, but it was raised in various capacities, specifically under the Environmental Change and Security Program, of which the Global Health Initiative is essentially a sister program, and my colleagues and I also wear hats on both programs. And under the Environmental Change and Security Program, we've held several events focusing on, most recently, Haiti, but also the DRC on gender-based violence. So I would love to talk to you more about it after the event and encourage you to go check out the website. But I think it's a good point to bring up and something to possibly explore in the future. So thanks for that. Does somebody on the panel want to specifically address the issues raised about the economics of the morbidities and the need for more research to identify the productivity that's lost? Meg? Go ahead.
My colleague, economist Tom Merrick, and I, several years ago, wrote a paper with support from the MacArthur Foundation on the impact of poor reproductive health, the economic impact of poor reproductive health. And then subsequently, we also did a review for the World Bank on looking at adolescent sexual and reproductive health, but more broadly conceived of, so to look at the impact on dropping out of school and future earnings and so on. And one of the things that we found, and I will say that we did that review, that second review probably 2 years ago, and I know there's been a big explosion of research on this precise intersection in the last few years. What we found was that we were continually obliged to borrow from other areas of health to understand the economic impact. So what would be the effect on workers of having another disease, or what was the impact of an AIDS-related death in the family on the health and well-being of other people in the family and the household economy. And so I just have to agree that I think it's very important. We need to make to me, the case is made by those, by that research that's been conducted in related health fields, but clearly it's not enough when we're trying to argue for a greater investment in maternal health. And so I do think this is an important gap. I also find myself, though, and I was thinking about this when you were talking about working with women parliamentarians in Kenya, that I do think it's important to get to have women in office and arguing on these important issues. But I cannot believe that maternal health is a specialty issue. I just, it boggles my mind. And so then we're thrown back on how important it is to make the economic case. But I find myself a little bit mystified, because everybody has a mother, is likely, it's the chances of becoming a parent are very great. You have children. How is it that people do not own the issue of maternal health? I don't get it.
Just to jump on what you just said, I think I agree with you, but also we have to recognize that maternal mortality is not a poverty disease, but it's very pregnant. It's very important in the lowest income part of the society, and the lowest part of the society is not always the most served by the system. So I think there is also an issue of who. And when we talk about mobility and when we talk about obstetric fistula, we are really talking about the poorest of the poor. And these are the women without any access to any services in still a number of countries. I wanted to reinforce what Marge and others have said about mobility. I think it's something that we know for long that we have to address that more seriously. I was lucky enough to be part of this MoMA survey in some years ago and to study mobility in the urban areas, because it was to go to real area to study this type of things in population require very important fundings. And we were able to demonstrate that the severe maternal morbidity was around 9% of the population, which is enormous in terms of disabilities, in terms of suffering, in terms of economic consequences. Some research are very interesting now. The London School published very recently the follow-up of women during years after a near miss, showing that the mortality among these women, even during a subsequent pregnancy, or just because the morbidity is severe, the mortality of these women long time after this event was still very high, and the difference between the population without complication and with complication was clearly important. So we know that there is here a very important part of the things that we need to address, and certainly during the next session we need to address. I wanted just to come back to a point about political will, because it's very interesting. I was in Bamako 2 weeks ago to talk about on a community of practice for financial access to care. And it was amazing to see how political decision could be, even based on the best willingness to give financial access to cesarean section to any woman in the country, can have so complex and sometimes detrimental impact on the quality and on the systems. When in Mali, for example, you have a system with cost recovery at community level, and you put vertically free care suddenly, and you destroy all the things that community were developing during years and years, because some donors and some institutions are pushing for government to take this political decision of free care, which is very good for pre-electoral period, but without not giving the assistance and without measuring the potential negative impact. So here we are talking about political will, and we are talking about the global environment and how the global community is pushing for things which are sometimes extremely difficult to analyze, and where we need to give more careful attention.
I just wanted to jump into our Human Rights Watch colleague who asked about accountability earlier. This has been an issue that has really plagued our field for a while. A colleague of ours, Helena Hofbauer from the International Budget Partnership, presented at our conference in 2010 with the title of her presentation was "Maternal Health is an Accountability-Free Zone." It's very difficult to hold governments accountable for their commitments. Appropriations are oftentimes not turned to allocations, most often. There's very little civil society budget monitoring going on especially in high-burden countries. We tried to seed that idea a little bit, and there's some work going on now in Indonesia and Nigeria that is encouraging and may provide us with a template to hold governments more accountable for their commitments to maternal health. And I also understand that the Accountability Commission that was formed out of the Every Woman, Every Child campaign is going to deliver some hopefully impactful results later next year, Luke, I think?
Yeah.
Yeah. So accountability is definitely something that we have not figured out yet, and that's a big issue in our world. And just to go to Meg's point about why is maternal health such an issue? I've been comparing. We had a conversation in a meeting we had recently about where is the urgent, passionate activism to improve maternal health that we saw in AIDS in the 80s. And the thing I think that has really amazed me, provoked me, is to think about the fact that AIDS is a collection of diseases, potentially curable diseases. There was a boogeyman at the top of the AIDS problem in the 80s, and that was the pharmaceutical industry. Well, they've come around, and now there's more treatment, and we're seeing declining infection rates in many of the hot zones of the world. That's very different from maternal health. Maternal mortality and morbidity is a collection of conditions and circumstances that are deeply rooted, as I said earlier, in traditional gender norms and other societal traditions. So I think when we scratch our heads why is maternal health such a distinct issue, I think that the next question is, why are women second-class citizens? It's the same question.
I know we're running over a little bit, but we started late, so I just want to give everyone an opportunity to maybe take one, maybe at the most two more questions, if there are any, before we break to go have some wine and celebrate. So a half hand back there. Did you still want to? Okay. All right. Well, I think we're ready to conclude then, and I just want to thank everyone again for coming and for being a part of not only today's session, but for the last 2 years. There's a lot of familiar faces here as well as new, and I hope that we can all continue to stay a part of these important dialogue sessions, and thank all the panelists for coming, and especially UNFPA and Maternal Health Task Force, African Population Health Research Center, and USAID's Bureau for Global Health. Thank you. Thank you all for coming.